you can put the mode, the parameters for pressure support. If you say the range is between 5 to 10 of your parameter that you want to put.
Okay.
Joanne,
okay.
anything?
Okay. Answers from Dr. Zhou.
Hello.
Hello, hi, Dr. Joanne.
I think some
technical issues. Okay. Never mind.
Recording stopped.
We'll proceed with the next question first. So, when Vapox can be used? Can Vapox used with all ventilators or only for certain type of only?
Okay. Vapox can be used in any situation, any cases that presented to you, because it's just the same that you beg the patient. The only thing is the machine is begging for you. So you set make sure when you select the machine, make sure the machine, the ventilator is a mechanical ventilated ventilator. They have the mode of like a NIV in that particular mode, and don't use the NIV like a CPAP machine because they don't have enough parameter inside. So if you want to use, they use this ventilator that can also perform mechanical ventilation, and at the same time also can perform non-invasive ventilation. So this is the machine. I'm not promoting, but sometimes example like Puritan Bennett, you can use your Hamilton, you can use your what is it? I can't remember that. The Philips. So what those machines that can mechanically ventilate and at the same time can non-invasive ventilation option, you can use it, right? So I think Vapox is useful for those patients like severe, like HOP killers, the severe metabolic acidosis. Then that's a very useful option if you want to use Vapox. Otherwise, you can use it any sort of patient.
Okay. So we shall proceed to the next two questions by Muhammad Anas. So is apneic oxygenation effective when upper airway is soiled?
Okay, right. So if you have a you need to clear the hopefully clear as much as possible the soiling issue. As a patient, a lot of vomiters, upper GI bleed. The only thing that it won't really effective if you have a upper airway obstruction. So it won't flow. Whatever you give on top, it won't flow till your alveoli. So you have a soil airway. Make sure like adjunct that I mentioned just now. Your adjunct. Use your adjunct. Use your suction well. Clear everything. Like a nasogastric tube. It depends. Like I say, it depends on the condition. And you can put your apneic oxygenation, and as far that there's no airway obstruction, so the oxygen can still flow to your alveoli.
Okay, all right. So the next question, in the rule of 15, that PEEP 15 is so high and uncomfortable, can the patient tolerate that, or do they need sedation for that?
Yep. Okay. Right. If let's say patient very combative or agitated, then not really responding to the higher PEEP, then you might need to give some sedation to calm the patient. Just calm the patient down so that patient able to tolerate with the 15 centimeter water of PEEP. Yes, you can give a bit sedation, but mind you don't want to put the patient really into sleep because you're not really prepared for pre-oxygenation. So choose your sedation to what is the appropriate sedation. You don't want to cause a respiratory depression. Suddenly you have no time for your pre-ox and suddenly patient desat. That's a common mistake that normally people do. So that's why I think the role of ketamine where to calm the patient At the same time, the respiratory function is still not being disturbed, and you apply your 15 centimeter water of PEEP for during pre-oxygenation.
Okay. All right. We'll proceed to the next question. In the situation when patient hypoxic and agitated, heart rate near 150, will it be safe for us to use ketamine to perform DSI? Will it worsen the heart rate? So this is quite similar to our second question. Yep.
Okay, so some of their concern is tachycardic. Yeah, I know that the patient already came with tachycardic. You give ketamine, further causing tachycardia. My concern is the can you calm the patient? Number one. What about the blood pressure of the patient? Okay, if the blood pressure is like a low or at the borderline, I'm more concerned on the blood pressure, and also I'm concerned about how to calm the patient down. This is different, like just now they mentioned about the symptomatic. Symptomatic is a totally different because we give midazolam. So this is a patient really in distress, tachycardic, required pre-oxygenation. Yes, you can give a low dose ketamine. Yeah, 0.5 is okay, 0.5, just to calm the patient down, and you can obey, you can tolerate whatever modalities of you give during pre-oxygenation. That is what we want. Okay, then you decide. Okay, after pre-ox, a few minutes, like 3 minutes, the patient improve, or you want to proceed with your intubation. That's the time you could, okay, I think we cannot, patient is really bad, let's say bad pneumonia, then we proceed with the intubation. Then you proceed, you give your induction agent and your paralytic agent and proceed with the placement. Okay, so to give ketamine in the low dose, I think not the concern of tachycardic so much, but we want to get a calmer patient for pre-oxygenation and to make sure the blood pressure is sustained accordingly.
Okay. All right. So let's proceed with probably the last question. For ARDS, as we know, the SpO2 is always critically low. So if you proceed with VAPOX, so what will be the optimal SpO2 you target, and also targeted PEEP and SpO2 basically? Yep.
Okay, right.
For VAPOX.
For VAPOX, okay, you can put so they advocate 15. You can put 15 for your PEEP. Your aim for saturation, I mean, before you want to intubate this type of very critically ill ARDS patient, aim I think up to 90% if you can get. But I'm sure you have been seeing a lot of patients that the lung is very bad to start with. Right? Even they can achieve like 87, 88. That's the most. If you pre-ox like half an hour, that's the most you can go. So that's why that if that's the maximum that you can reach during that particular the timely period of pre-oxygenation, then you have to you have to ensure the placement is very smooth first pass success, and always anticipate the patient can deteriorate, because the safe admit period is already very short. So the placement must be really smooth. That's why you need to have an experienced operator. So you cannot aim like 95. I want 95%. I think until tomorrow you cannot get the 95%. So it's because the lung is very bad. So I think whatever you can achieve within like 3 minutes, then you have to proceed with the intubation.
Okay, thank you, Dr. Zul. All right. So by the way, is Dr. Joanne on the line already? Would you like to proceed? Yeah, proceed with the question.
Joanne, any comment?
Idea?
Okay, sorry about that. I think I have a technical hitch because of the VPN here. Okay, are we going back to the questions on the VAPOX just now on the CO2 retention patient?
Yep.
Okay,
the question.
I think I'll just flash the questions again. I think, okay, is in using VAPOX technique in patients with a CO2 retention, is there any role to put the pressure support in the setting? And what will be the recommended PS setting for this patient? What I was going to say is the approach to these questions, I think I'll rephrase it a little bit, because CO2 retention, there are two extremes of, there are two different cohort of patients. One of them is a CO2 retentions, but the patient's maintained is a consciousness, and the conscious level, it doesn't have any automental sensorium. And the other one is CO2 retentions with the hypercarbon respiratory failure, and the patient is totally obtunded. So in using a VAPOX technique is, I would say, is definitely superior than any of the non-rebreather technique, or with the non-rebreather, with the apnea oxygenations, or even with the back vomus ventilations with the apnea oxygenations and in situ. So if this patient is a CO2 retentions, but the patient is not obtunded, and you're going to institute a VAPOX technique, a pressure support might be useful, and you can actually start low, because it's the aim of a pressure support is to actually strengthen the respiratory muscles, and it does not really interfere with the patient's own spontaneous breathing. So it kinds of gives patients comfort when the patient is still having his own spontaneous breathing. At the same time, it helps the patients to tolerate the VAPOX technique during the pre-oxygenation period. But if the patient is a CO2 retentions with the hypercarbon respiratory failure, and the patient is already obtunded, the use of a pressure support, I will say, is not mandated. And I really didn't know whether it's going to help the patients much or not, because after all, the patient is already obtunded. The comfort can't be analyzed and it can't be measured. And if you think that, in terms of, strengthening the respiratory muscles and improve the pre-oxygenation, and you want to institute your pressure support, you want to administer it and set it during your VAPOX, I guess it depends on a pragmatic approach. So it depends on the physicians on the floor and their own preference. I hope I hope anyone with the different feedback or opinion. So it really depends on your patients. All you have to do is to look at your patients. If they are conscious, I think the pressure support might be helpful. Okay.
Okay. Thanks, Dr. Joanne. And I think we have covered all of our questions. So next, okay, we would like to have a photo session with all participants. So dear participants, please just turn on your camera. And before that, we would like to update everyone about our next CASTER event. So it's the Advanced Adult Emergency Airway Management Course 2022 organized by CASTER Malaysia. So it will be in August 20th or 21st, which is Saturday and Sunday. So in UM, and we will open the registration in early July. So just stay tuned with us. All right. Okay, so next we'll proceed to our photo session. So everyone, please turn on your camera.
Could Dr. Zul please stop sharing your slide first,
sorry.
And I will have to. Yes, everyone is welcome to be in the photo, and I'll try to accommodate everyone. All right, let's see if I can.
Yeah. Okay.
So sorry if I can't accommodate most of you, but I will try. You can just turn on your camera and be in the. Okay.
In the lecture hall.
Lecture hall. Okay.
Oh, this is cool, man. Lecture hall.
Okay.
Some persons can see the participants as a thing. Okay, let's see if I can have the gallery view. Probably gallery view is much better.
Okay.
Okay, so I think this is gallery view for everyone. I can just You look natural and just smile to the camera. Okay. All right. Hold on. Let me see if I can just get it done again.
That option.
Okay. Don't have the options to open the camera, but okay. For some reasons, the participants can't turn on their camera. Okay, never mind. Just a quick one. Okay, no worries. If you don't have a camera, we have your names on the list. Okay. All right, back to you, Ningan. Yeah.
All right. Okay. So for participants, you may get the CBD credit points by scanning the QR code using your MMA apps. Okay, we'll show it. All right. And then after that, you may also get your e-certificate of attendance by clicking a link. Just share in the chat box. So you share it for a couple of minutes.
So you guys can scan the QR code that are being put up on the slide. Okay, using your MMA app scan.
Okay. Just a reminder that you can also you can get your e-cert via the link as posted in chat box. Okay.
So I think we can give some time to the participants to actually click on the link, and you can fill up the details needed, and you'll be receiving the e-certificate of attendance on your email immediately.
Okay.
Okay. Please let us know if you have any problem at the moment. Probably Ningan can ask them if they have any questions at the moment.
Any more questions? So if they're at the recording. Okay, so again, we would like to thanks to Dr. Zhu for the interesting talk and to audience who made this Zoom series possible. So thanks for joining us today, and stay tuned with our next event. Okay, so if you have any question, you may email or message us in the chat box. All right.
Before you leave, please make sure that you have the link downloaded or cut and paste or copy to your cell or your tablet. And then you can maybe, Dr. Zhu, could you please just flash the QR code again, just to make sure that we give it another 5 minutes before they leave?
Yep.
Because there are quite a large number of audience this morning, so let's just make sure that everyone gets the QR code, the MMA credit, as well as the e-certificate of attendance before they leave the platform. Okay, we have a questions from the Philippines audience. What is the IC number? If you don't have the IC number, you can just key in your name. If any identity numbers that you need, you can actually key in your passport number. Yep. And while we're waiting for our participants to click on the link for the e-certificate, just to promote again, our Advanced Adult Emergency Airway Management course will be on the August 20th to 21st. We have very distinguished speaker and trainers from Singapore, Philippines, as well as Malaysia. So please stay tuned for the July, our registration is going to start in July, and there are only 60 seats available because we focus mainly on simulation training. If you're interested in if you have any questions that we didn't really manage to answer, or you have it later on after the CME, please drop it to this email address, and we will answer them and get back to you via the email. Okay, so please email us if you have any questions. Okay, please as well, the recorded lectures from series 1 to 3 up to date will be posted on the website later on in July. So please stay tuned for the recorded versions lectures. If you did not manage to join us this morning or from the previous 2 CME that we had conducted. So don't worry, we will be sharing the recorded versions later on. Okay.
So how's Joe? Are we going to call off?
Okay, I think we're good. We still have, okay, thank you all the participants again. We'll see you at the next CME. Goodbye for now.
Recording stopped.